Another possible cause of heart failure, secondary heart failure with preserved ejection fraction, which I want to discuss with you because it is actually mentioned in this paper, is mitral stenosis. With mitral stenosis, we can see it quite nicely visualized over here. So this is a severely calcified valve. So this is a degenerative mitral stenosis. We also have calcifications all around the mitral valve, the LVOT, the papillary muscles, the coda tendina even. And here we do see the definite reduction of the opening of the valve and the severely enlarged left atrium. Also, this patient had atrial fibrillation. And what we can nicely visualize with color Doppler is this color Doppler signal which enters the left ventricle from the mitral valve. It looks like a candle flame. This is suggestive of mitral stenosis, and in this case it was moderate to severe mitral stenosis. The problem with mitral stenosis and heart failure with preserved ejection fraction is that the filling pressures very often do not play an important role, but we do see similar findings. We do see that left ventricular function, in this case, is preserved. It's leading to a dilatation of the left atrium because, of course, we have a hindrance for blood flow, so we have an increased pressure of the left atrium, but not of the left ventricle, because the left ventricle is even protected by this stenosis of the mitral valve. We have, of course, due to the hemodynamic sequelae, a dilatation of the right ventricle and a reduction in right ventricular function. We have a dilatation of the right ventricular annulus, the tricuspid valve annulus, and we have a dilatation of the right atrium and evident pulmonary hypertension if we measure systolic pulmonary pressures as well. Still, we have very rarely elevated filling pressures. As I mentioned, the left ventricle is mostly protected by the mitral stenosis, and we have to keep in mind that certain measurements are simply not possible. For example, E2E' is not possible due to the severe calcifications we see over here, so that won't be a valuable measurement and doesn't denote if filling pressures are likely elevated or not. So in mitral stenosis, it's very hard to elevate filling pressures, but mostly if MS is relevant, filling pressures are most likely not elevated, especially they are not elevated by mitral stenosis. There could be another disease entity which causes, of course, elevated filling pressures, but mitral stenosis protects the left ventricle. I want to review again the diastolic dysfunction from the guidelines. Of course, more information as mentioned, just check it out in the full video of diastolic dysfunction. In patients with normal left ventricular ejection fraction, we can differentiate if we have normal diastolic dysfunction or if we simply do not know, or we have diastolic dysfunction. We have to measure the E2E', the septal E', the lateral E'. We can measure the TR velocity and the left atrial volume index. In patients with reduced ejection fraction or diseased left ventricle, diseased left hearts, we have three trees we can follow. We can follow the left tree, which shows us normal left atrial pressures, a grade 1 diastolic dysfunction, which already states if patients are symptomatic, so if they have dyspnea, we should consider coronary artery disease, or we should even proceed to a diastolic stress test. In the middle area, the middle part of the tree, we see that, of course, we start always with the E to A ratio. If it has certain numbers, also the E maximum velocity, you can see quite nicely over here. We have to move to the second part of this tree where we can delineate or where we can differentiate if there are most likely normal filling pressures present or elevated filling pressures present, or we simply cannot determine left atrial pressures and diastolic dysfunction grading. The E to A ratio above 2 or 2 is a grade 3 diastolic dysfunction, restrictive filling pressure. This means elevated left atrial pressures, elevated filling pressures.